Hello and welcome. My name is Fearghal McKinney, Head of British Heart Foundation, Northern Ireland, and I'm delighted today to be hosting this afternoon's BHF Live and Ticking event. Our online events keep you up to date with the BHF's latest research news across the UK, from research pioneers and incredible heart stories to celebrating our amazing supporters and fundraisers. Each month, we're delighted to bring you the latest BHF news and pioneering research stories. The British Heart Foundation is the largest independent funder of heart and circulatory disease research in the UK. We've invested 10 million into research in Northern Ireland. For more than 60 years, the public's generosity has funded BHF research that has turned ideas that once seemed like science fiction into treatments that save lives every day. We've funded decades of research, which has led to the discovery of many of the faulty genes that are responsible for causing inherited heart conditions. However, there are still many which are unknown. It's estimated that here in Northern Ireland, 17,500 people have a faulty gene, which puts them at an unusually high risk of developing heart disease or dying suddenly at a young age. So we're delighted to have experts with us today to talk about the research into inherited heart conditions and hear from the medical experts on the ground. Today, I'm delighted to be joined by Professor Declan O'Regan. Professor O'Regan is Medical Research College investigator and consultant radiologist and director for imaging research at Imperial College Healthcare NHS Trust. He and his team are using the latest technology, harnessing artificial intelligence to help predict how cardiomyopathy will affect individual patients. Today, he will be sharing his research into how AI can help doctors and cardiomyopathy patients in the future make more informed choices about their treatment and accelerate the discovery of new treatments. We're also joined by Joanne McOsker, nurse specialist in Inherited Cardiac Conditions Service at the Belfast Trust. In 2017, Joanne and her team received funding from the Miles Frost Fund, which was set up to help make genetic testing available to families affected by the potentially life-threatening condition hypertrophic cardiomyopathy. Belfast was the first city in the UK to benefit from the Miles Frost Fund, which was set up as a collaboration between Sir David Frost's family and the BHF. I'm also delighted that we have Nicola King from Coleraine with us today. In 2020, Nicola's daughter, Lucy, survived a cardiac arrest at just 13 years old. The family later learned she had a genetic heart condition called left ventricular non-compaction cardiomyopathy. After tests, it was discovered that Lucy's dad, Richard, and two siblings also carry the gene. Thank you to Nicola for joining us. We look forward to hearing about your personal experience later. We'll finish today's event with questions submitted by our supporters, but without further ado, I'm delighted to introduce Professor O'Regan.
Great, thank you very much for the kind introduction. Let me just share my slides. Great, thank you very much for the introduction. So my name is Declan Regan. I'm a radiologist from the Medical Research Council in London. So my background is very much focused on imaging of the heart and understanding cardiomyopathy through advanced imaging and using artificial intelligence to better understand the causes of cardiomyopathy. So much of the work that we do uses MRI. So this is a very safe technique for studying the heart. Here's an example of actually one of our radiographers having a scan at our unit. So this delivers fantastically detailed pictures of the heart. And there's no radiation involved, so we can use it for following patients up. We can use it for screening family members and so on. And it gives really unprecedented detail of the heart to try and really develop a detailed picture of how the heart is affected by cardiomyopathy. So this is just an example here of some of the images that we can obtain, and these are taken from 8 different patients with different types of cardiomyopathy. So some of these are very common. We'll talk about them a little bit later. Hypertrophic cardiomyopathy is this abnormal thickening of the heart muscle. This is actually one of the leading causes of sudden cardiac death, particularly in young adults. Dilated cardiomyopathy is a form of cardiomyopathy where the heart becomes abnormally thickened and enlarged. ARVC we've seen is actually a cause. We've seen a few footballers and cricketers recently who've been affected by this. Can often be exacerbated by exercise and lead to cardiac arrest. There are also diseases here which are multi-organ diseases which affect the heart, like sarcoidosis and amyloidosis. And these can sometimes mimic the effects of genetic disease. So cardiac MR can be incredibly useful technique for being able to reach an accurate diagnosis. Being confident isn't something else that looks like cardiomyopathy, and also for screening family members, because we can accurately identify the really early stages of disease before people become at greater risk of complications. So just some definitions, really. Artificial intelligence. So this is essentially the technology to efficiently achieve complex tasks independently. So like driving, driverless cars, for instance. Much of the work that we use is actually more narrowly focused on machine learning. And these are sets of programs really that improve their own performance without the need to be programmed. I'll give you some examples of that. We use a form of machine learning called deep learning, which is essentially modeled on the way that our brains are wired up using these neural networks to help make accurate predictions. So a lot of the work that we're interested in doing takes those images from cardiac MRI scans, which we routinely analyze by hand. We take measurements from, we use our judgments to kind of reach a diagnosis. What we want to do is to make those clinical images into a form that a machine can understand. And we use these sorts of neural nets here, where we take an input image, like an image of the heart, and we convert that into a map of the anatomy of the heart, where each structure in the heart is and how the heart moves. So this is the sort of output that we get. So every single pixel in this MRI image is mapped to a moving model of the heart. And we can do this almost in real time. It's fantastically accurate, fantastically quick. And we can also move one step further in that the heart itself is a three-dimensional organ. You can only really understand it in 3 dimensions. So we can create these sort of digital twins, if you like, to make a really accurate digital model of how the heart moves, what its shape is, and so on, and how it's different between different people. So this is just an example here. We can take those images, we can build like a 3D meshwork of the moving heart, and we can study it in really exquisite detail. So one of the important things is actually about individualizing predictions. So if you have a patient in the clinic who's presented with certain symptoms, or someone in their family has developed symptoms, one of the key things is to be able to give them a prediction of what to expect in the future. I think that's something that we're probably poor at doing in general. And so this is an approach to try and improve that. So what we do, we take those images and we analyze them in the way that you've seen before. We convert all of those images into a digital format. And the model on the right here shows actually how we can summarize the motion of the heart actually this is nearly 400 different patients with heart disease. And these colored lines shows how the surface of the heart moves at hundreds of points in time. And actually we can integrate data from many patients into a single electronic model of the heart. And that lets us train machines to accurately predict someone's outcome, because everyone's heart is different. And this sort of approach allows us to kind of personalize those predictions. And this is something that we're working now on rolling this out into clinical use. So people have their routine heart scan. They'll also have other data collected, blood tests and ECGs and so on. It'll pass through this algorithm, which only takes a matter of seconds to analyze those images. And then the radiologist or the cardiologist who's analyzing the images will have a really personalized prediction of how that patient's condition may change over time. And that's incredibly valuable for deciding with the patient what best treatment, what best management to consider. So we'll touch on one particularly common cardiomyopathy, that's hypertrophic cardiomyopathy. And this is where there's abnormal thickening of the heart muscle. This affects about 1 in 500 people. And you can see these cardiac MR images here show how thickened the heart muscle is. In this case, it's over about 3 centimeters. So that's 3 times the normal thickness. And as I mentioned, this is one of the leading causes of sudden cardiac death. The question is, what about screening? Could we screen the population and look at genetic differences that we know are associated with hypertrophic cardiomyopathy, with HCM? So we used a fantastic resource, which is UK Biobank. 500,000 people across the UK have volunteered to donate their DNA to UK Biobank, and many of those have had cardiac MR imaging as well. So the upshot is that about 1 in 40 people have possible variants, genetic differences that might be associated with HCM, with this type of cardiomyopathy. So surprisingly common, though many we think of those are probably relatively harmless. That leaves about 1 in 400 people who actually carry a gene which we know is definitely associated with HCM. So the question is, what do their hearts look like, and actually what risk do they have of having complications? So again, here we can use our algorithms to analyze those images. We've actually analyzed here images from 40,000 people and also track the motion of their heart and look very carefully about differences in their heart muscle. The image on the right here, the areas in red in the heart show where the muscle in the heart is abnormally thickened. So we know that these genetic variants, they do carry extra risk in the general population. What they don't give you is the full-blown disease. So you've got what looks like a very mild form of the disease, which actually could pass for a relatively normal heart. So what happens in families who have these genes seems to be very different to what happens to a random person in the community who has the exact same gene. So there are important differences in HCM that runs in families compared to those same genetic differences when we discover those incidentally in the general population. So I just wanted to finish on some work that we did with patients and cardiomyopathy nurses a year or 2 ago. And this was really exploring their journey through diagnosis and treatment. And I think it's really important for researchers to have, you know, this sort of close contact with patients and hearing their stories, so that we can help decide where research can help to improve that. Now, I think what was really striking was actually the delay in diagnosis that many patients had, the sort of fear and frustration about the uncertainty around diagnosis, and actually really wanting the right information that was tailored to them, having really sort of a balanced view, not overselling or underselling the risks, so that they can actually become, you know, involved in joint decision making about their condition. So I think it's a really, really valuable thing to do, and I think we all learned a lot from it. But one thing that we wanted to focus on really was the use of machine learning and AI and data science in this, how patients felt about that. Did it feel depersonalizing in many ways, thinking that a machine might be involved in your care? But I think actually most people are actually very positive about this, and they were positive about it because they felt that this was a way in which they become more engaged in their own healthcare. They have more ownership over the information that was being shared about them, and actually more visibility of the information that was available from the doctors, that they could have more ownership about and improve communication and joint decision making. So I think the responsible use of AI was really supported, but I think that was against a background of a lot of difficult experiences I think that patients had in reaching a diagnosis and being able to decide on the most appropriate treatment for that. And that would be something that would be really interesting to hear from the King family later on. So I'm going to end there, and I just wanted to emphasize how important support is from the British Heart Foundation for this research. None of this would be possible without that. But also to thank all of the people in lots of different research teams, from imaging to genetics to therapy, who all make this sort of research possible and offer the opportunity for improving outcomes for patients. Thank you.
Declan, thank you very much indeed for sharing your time and your knowledge and reflecting on collaboration and looking to the future. It is really quite inspiring. And now can we join Joanne McOsker from the Belfast Trust.
Thank you, Fearghal, for the introduction. I'm just bringing up my slides. So thanks, Fearghal, and thanks for the opportunity to participate in this session. Just as a brief background, brief introduction to my own background, I have worked in the field of cardiology for many years and have worked as a nurse specialist in the Inherited Cardiac Condition Service. We're based at the Belfast City Hospital from 2006. It is an area that is of particular interest to me, and I find it very rewarding, and I'm involved in the care and management of patients with to be able just to provide an overview of what inherited cardiac conditions are, why and how patients are referred into our service, and what happens when patients come to the clinic. And I just wanted to mention some of the challenges that we had experienced with an ever-expanding service, and how funding from the British Heart Foundation over the years, and more recently through the Miles Frost Fund, has impacted significantly in enabling us to provide a more efficient and effective service. So inherited cardiac conditions are defined as a group of genetic disorders primarily affecting the heart structure and electrical conduction system of the heart. The initial presentation of a proband in a family may manifest as a sudden cardiac death. However, the majority of families who are referred to our service, sudden death is not the initial presentation within that family. The proband is the first person to present within a family with an inherited cardiac condition. And when an ICC or inherited cardiac condition is suspected and or diagnosed, this has implications for first-degree relatives who may be at risk of having or developing the familial condition, and they may be entirely asymptomatic and feel very well. So it can come as a shock to them when they're advised about having screening, and particularly if a confirmed diagnosis is made subsequent to their screening. So in terms of the normal structure of the heart has different components. It has different rooms or chambers in the heart that fill up with blood. There are heart valves between the chambers that open and close a bit like doors to ensure the blood flows in the right direction. You have got heart muscle that does all the pumping and squeezing, heart arteries that feed the heart muscle, and you have an electrical conduction system that sends electricity through the heart in order for the heart to beat. And so the types of inherited cardiac conditions that we see at our service most commonly would be cardiomyopathies and channelopathies. So cardiomyopathies cause abnormalities with the muscle of the heart, and there are different types. As Professor Regan alluded to, hypertrophic cardiomyopathy would be the most common, which causes an abnormal thickening in the heart muscle, and there may be a slight increased risk then of having heart rhythm disturbance. We do also see dilated cardiomyopathies, left ventricular non-compaction, and restrictive forms of cardiomyopathy. Channelopathies then affect how electricity conducts through your heart, so it causes abnormalities with the switching on and off of electricity in the heart, and primarily patients who have these conditions may be at increased risk of heart rhythm disturbance, and these conditions would be known as long QT syndrome, Brugada syndrome, or catecholaminergic polymorphic ventricular tachycardia, or CPVT for short. Long QT would be the most common channelopathy condition that we see at the clinic. And then we see the families where there has been a sudden death in the family, where their family member has sadly passed away unexpectedly, and at post-mortem there is no definite cause of death found, and therefore the cause may be related to an underlying heart rhythm disturbance. We also see other conditions less commonly, so aortopathies affecting the aorta and blood vessels, muscular dystrophies which cause weakening in the muscles in the body and can cause cardiomyopathy, and rare metabolic disorders that can affect multiple organs in the body, including the heart, such as Fabry disease. So in terms of why and how are patients referred into the service, so we see probans with a known diagnosis who may have been referred by their local cardiologist for advice on complex cases, for their management, and for genetic testing to look for gene alterations that may be associated with the condition. We see probans with a suspected diagnosis of an ICC, and they come to us for further or additional investigations to try and confirm or exclude a diagnosis, and that would also entail having genetic testing screened to look for genetic mutations. And then we see the first degree relatives with a family history of an ICC or where a sudden death has occurred, and they come for clinical screening and for genetic testing if a gene has been found within the family. And then patients are referred from various sources. Many of our referrals come from GPs, and often they would refer the relatives for screening where they have a family history. General cardiologists refer probans. We do get some referrals from geneticists for the aortopathy patients who have already had assessment at the genetic service, and they come to us for clinical screening and assessment of their heart. Coroners and pathologists will recommend a referral for families where there has been a sudden death has occurred and the cause of death has not been identified. And then also we receive a number of referrals from neurology and nephrology patients, and they would be patients who may have muscular dystrophies and metabolic conditions such as Fabry disease. So over the years, really, as our service has evolved, we've built up an ever-expanding service. There's greater public awareness about inherited cardiac conditions, and this may relate to high-profile cases, such as the Frost family, where there have been inherited cardiac conditions or sudden death. Within our service, we had been experiencing pressures with capacity to see patients in a timely manner, and this was due to an exponential increase in the new patient referrals over a period of years, with demand significantly exceeding capacity. And so following a bid to the BHF Miles Frost Fund in 2017, as Fearghal alluded to earlier, Belfast was the first service in the UK to launch a new Miles Frost funded nurse specialist post, and this came following the death of Miles Frost, sadly, to hypertrophic cardiomyopathy. And it had come to light in the Frost family that David Frost, Miles's father, had been found to have the condition at post-mortem. He had died a few years earlier. And the Frost family raised a lot of money in order to set up cascade screening clinics across the UK so that there was a higher uptake of patients who could have clinical screening and genetic testing to look for evidence of the condition. And the impact of this on our service has been very significant, but we have been able to increase the capacity to offer more new patient appointments for families. And we've been able to do this by establishing nurse-led clinics, and we also appointed an administrative coordinator post who assists with preparation for clinics and collates patient information. So really for patients, this means that they can be seen in a more timely manner for clinical screening and to access genetic testing. It means that patients who are at low risk of the family condition can be reassured. And for patients who are found to be affected and receive a diagnosis, they will be managed clinically and will undergo risk stratification to identify patients who may be at high risk and then they are managed accordingly to reduce the risk of sudden death. And since 2017, nurse-led clinics have seen an additional 300 new patients per year. However, this number has not been consistent due to a number of factors and unforeseen circumstances related to, certainly over the past couple of years, the pandemic, where staff have been redeployed and so on from the service. So what happens when patients come to the clinic? So patients are either triaged to the consultant or nurse-led clinic, whichever is deemed to be most suitable. Previously, all patients were seen at face-to-face clinics. However, over the past couple of years, we have developed virtual telephone clinics due to there being restrictions on footfall within the hospital settings. And these have worked really well, and we've had good feedback from patients. However, they're not suitable for all patients who then would be offered a face-to-face appointment. So prior to the patient's appointment, they are contacted by the coordinator to try to work out, is the family known to our service? And if not, the nurse specialist will do a telephone pedigree or family tree with the patient prior to their initial appointment. In the event where there's been a sudden death, we liaise and have close links with the coroner's office and pathology teams to access the post-mortem report to confirm whether there has been a cause of death identified or not. And then at the clinic, patients will undergo assessment with a detailed medical history, and they will be asked about whether they have any cardiovascular symptoms. They will have a series of cardiac investigations. We do aim to have a one-stop shop approach for face-to-face patients, and they would receive their results on the same day of their clinic appointment. The number of investigations that they would have would depend on the condition that they're being screened for. So we undertake ECGs, echocardiograms, heart monitors, exercise stress tests, and cardiac MRI scans. And then for patients who have a confirmed diagnosis, they would undergo risk stratification, and a management plan would be put in place. So we would look at treatment options, whether they require any additional investigations, and that they have a follow-up review plan. And then patients have access to genetic counselling and consent. So the probands would be screened for genetic, to see can we find a genetic mutation that would be associated with their condition, and first degree relatives would undergo predictive testing if a gene mutation has been identified within the family. It's important that patients receive appropriate education on their condition so that they can take ownership, and also that they have a good understanding and that they are aware of worrying symptoms to look out for and report. We provide lifestyle advice in relation to restrictions on certain types of exercise which may increase the risk of heart rhythm disturbance, and on other aspects such as driving, insurance, work situations, and drugs to avoid, particularly in relation to some of the channelopathy conditions. We also provide family screening advice, and patients are provided with contact details for the service should they have any additional queries or concerns at a later stage. So for the majority of patients diagnosed with an inherited cardiac condition, they are well and asymptomatic. They don't have any cardiovascular symptoms, and their risk of sudden death is deemed to be, would be in a low risk. However, we do recognise that for some patients, they may have significant symptoms and may have high-risk features from the condition, and these warrant medical therapies and consideration of implantable cardio defibrillators if deemed appropriate. And this can have a significant physical and emotional impact for patients and families that can cause feelings of anxiety, distress, fear of sudden death, and there can be feelings of guilt, particularly related to genetic conditions and in situations where parents have maybe passed the condition on to their children. So it is important to have access to screening where they have assessment of cardiac function and genetic testing for a familial condition, and a timely diagnosis and management plan will hope to reduce the risk of sudden death by identifying high-risk patients and managing them appropriately. Patients have access to medical advice and support initially while they are waiting to be appointed, during their clinic appointment, and between review appointments for any queries or concerns they may have. And also then some patients find it helpful to access more specialist counselling sessions, particularly if they are finding difficulty in coming to terms with their diagnosis or other aspects of the condition. So we can make referrals to clinical psychology services or other services if patients are experiencing difficulty. And so these are just a few of the events that the service has been involved in and highlight the achievements we've accomplished with the support of the British Heart Foundation funding into inherited cardiac conditions and genetic testing. We had attended Stormont just for an afternoon tea, and then this was the launch of the Miles Frost funded nurse specialist post in 2017, and in 2019 attended the Heart Hero Awards and were finalists for our nurse-led cascade screening clinics. And finally, I would like to thank all the team members in the Inherited Cardiac Conditions Service for their contribution to providing a quality service for our patients. I'd like to thank the BHF and also the viewers who will tune into this session. Thank you.
Joanne, thank you very much indeed for that comprehensive overview of the service. Best wishes to you and the rest of the team. We've been delighted to help celebrate the success of your service. But of course, stay with us as we may have some questions for you later from our supporters. And we're now joined by Nicola King. And as I said at the outset, Nicola's daughter Lucy suffered a cardiac arrest in 2020. And she joins us now to tell the story of Lucy and her journey since that day.
Hi everyone. So again, just a brief introduction. My name's Nicola and I live in the north coast of Northern Ireland, just a few miles from the Giant's Causeway. I live with my husband and 3 teenage children, Thomas, Lucy and Olivia. Just a bit of background to myself. I have been primarily an intensive care nurse for the past 27 years, but just before lockdown, I managed to escape the rat race and I'm now lecturing in health studies, trying to inspire future nurses into nursing. So that's my background. So yeah, it'll be 2 years next month, living a very normal life, children never sick, very healthy, sporty family. And one morning at about 6 o'clock in the morning, Lucy, my middle child, made a really loud noise in her bed. We thought maybe she was having a bad dream. But it went on for a little while. So we all ran in. Luckily, we all sleep with our doors open. Ran in and she was very static in the bed. She was awake with her arms stretched out, but she wasn't really there. And very quickly, she just collapsed into the bed. So immediately, with my intensive care background, I pulled her onto the floor and started doing CPR. Couldn't believe what I was doing. Wasn't sure if it was her heart or her brain. And my son, it was snowing that morning. My son, he ran his pajamas to the shop. He knew where the defib was. So we worked on her and the ambulance came. They were fantastic. She needed shock twice and then they did get her back. So she was transferred up to Altnagilvan Hospital, who were amazing, fantastic, and she was intubated and ventilated, and that's the first time that they mentioned cardiomyopathy. Completely shocked, couldn't understand. Lucy, I myself have a history of SVT, which is palpitations, can be completely normal. And so Lucy had an echo when she was in P3, had 24-hour ECGs, everything was normal. So we couldn't understand where this was coming from. So then she was transferred up to the Royal, further tests were done, and this non-compaction cardiomyopathy was mentioned. Lucy had to learn to walk again, how to talk again. She still has some residual brain injury. She has a classroom assistant, but she's doing amazingly 2 years on. She does have a dual pacemaker and defib in situ, which is hardly needed to be used at all. and that's the story of Lucy. You know, our family are very fit and active, and actually my son as well, only a few months before Lucy took sick, had the cry screening that everybody would have at his local rugby club, and his was normal, but he has the same heart as Lucy, which we went on to find. So it's very scary. I remember people asking us, any sudden death in the family? No, we're all really fit and well, never sick. So yeah.
So, I mean, I started by saying your journey as if it is just a journey, but of course it's a deep, deep dive into, you know, heart conditions, as it affects your family, looking back in history of your family, looking forward. Just how does it impact? I'm fortunate enough to have met you all, and what a family, if you know what I mean. It smiles. You can tell that they're such a bonded unit, but it must have been tremendously stressful on you all.
Yeah, to go from complete, you know, Richard and I would always have used the saying, your health's your wealth. Aren't we so lucky? We're so healthy. Our children are so healthy. And that all came crashing down 2 years ago. Crazy. None of my children have had any symptoms. Lucy and Olivia, my two girls, are champion Irish dancers. The week before Lucy took sick, she competed at the Northern Ireland Championships. No signs or symptoms at all. My son is so fit, could run rings around anybody. Turns out it has come from my husband. He's 45, again, played football, was in the Scouts, climbed every mountain going, partied a bit out at uni. You wouldn't know now that he's actually in first-degree heart failure. You wouldn't know that. And then it found that it's come from his mum. So she had it. She's in her 70s. Unfortunately, it only passed to Richard. Well, no, it's good. It didn't pass to his other siblings. It's only come down through Richard. And unfortunately, he's given it to all three of our children, which is very unfortunate. But yeah, it does make you re-examine your life and appreciate the small things. I think.
Sorry, go on.
No, I think I truly believe that's why I was meant to be a nurse now, to be there and to be able to do that. And I feel like because I have all the knowledge, that I'm really able to fight for them and be the warrior and drive them forward and do the best I can for them. And nobody's promised tomorrow. Yeah,
yeah. And how important has it been to be able to lean on the research that has been done?
We all know, and myself especially, the NHS is under huge pressure at the minute. And without the British Heart Foundation research into cardiomyopathy, you know, probably we're dealing with day and day things with NHS. So for advances to happen in cardiomyopathy, no doubt we need the work of the British Heart Foundation there for that to progress.
Yes, and obviously we're committed to that research going forward. And how do you feel when you listen to Declan O'Regan's presentation and you see there I mean, it blows my mind in terms of just looking at it, what people like Declan and his colleagues are involved in. But how do you feel when you see that type of research, but know your story, the practicality of it as it affects your family?
Well, really interesting for me. It was really interesting to watch that and use my family as guinea pigs anytime. If we're to move forward with this, just helping people. I had no idea how common cardiomyopathy was until I was thrown into this. And so many people that we've met in our local community now that have the different types of cardiomyopathy, you just don't know what's around the corner. Sorry, I have some photographs there. I don't know if they want to stick them on just so the family forgot to say, but this is how weird the disease is. I mean, well, the first one there was Lucy, like, loves being sporty. That's her. She was running into the sea on Christmas Day. And also 5 months after Lucy had her cardiac arrest, as a family, you'll see pictures later on, we were able to climb to the top of the Mourne Mountains, which is the highest mountain in Northern Ireland, with no issues at all. And yet they all have cardiomyopathy. So there she is with the celebrity there. That's just us. That's us at Christmas time. That's Lucy with the cream.
Well, all I did is to get to come up and say hello to you. You've got to get through it, and the researchers have got to get through the work, and the practitioners have got to do all the rest of it. So it's fantastic to hear your story. It's fantastic to hear that Lucy's doing so well. I know that young son is restricted in his rugby training, but
yes, that's very frustrating because he is so sporty. And, you know, you hear of kids that just lie about in their phones or Xboxes all day, and that was never my family's you know, Thomas is a scout. He's constantly was playing rugby, loves his sport. And, you know, kind of, that's the frustrating thing, I suppose, because the research isn't there yet. It's kind of a blanket ban on things like that. But again, you have to think about mental health. You have to think about balancing the risk. And, you know, obviously when we first were told about this, it was right, no sport. But actually, I'm not going to wrap Thomas up in cotton wool, because what kind of a life is that for a child that just loves sport so much? So it's just weighing up the risk and taking a sensible approach to it. And he loves his surfing. Now, he doesn't play rugby. He doesn't ask every so often, please can I go back to rugby? Plays a wee bit of football and goes to the gym. But that's what he loves. So, and nobody's promised tomorrow. So we have to weigh it all up.
Yes. Well, Nicola, thank you very much indeed for coming along today and sharing your story. It's stories like yours and the commitment that you've shown since to the BHF that inspires others in your community and further afield to continue helping the BHF to achieve its ambition going forward to really make a difference when it comes to survival as it relates to heart. So now I promised you all that we would look at some supporter questions. I've not got them in any read order, but I'm going to kick off with Joanne. And some of these are specific, so forgive me, but from Susan and for Joanne, what effect does a left bundle branch block have on your heart?
So, so the left bundle branch block, electrical conduction travels down the left bundle branch block to the left ventricle, which is the main pumping chamber in the heart. And in patients with this finding on their ECG, it means that there is a delay in electrical conduction getting to the heart muscle. It may be primarily due to an underlying electrical conduction pathway abnormality, or it may be due to an underlying structural heart abnormality. So if this finding comes to light on an ECG, the patient would warrant some investigation to try to see if there's any obvious explanation for the left bundle branch block. It is actually a finding on an ECG that can be present in the population, and it just is something that's picked up incidentally, and the person is well and entirely asymptomatic. And in that situation, the patient may just warrant some intermittent follow-up and reassessment of their heart to see if anything else is picked up at a later stage. So yes, patients can be well with left bundle branch block, but it's really about trying to work out what's the underlying cause of it and whether it warrants then any investigation, or sorry, any treatment if there is an underlying cause identified.
Okay, Joanne, thanks very much indeed. Nicola may have alluded to this in her testimony earlier on, but this is for both Joanne and Professor Regan. And could a family have an inherited heart condition and then it just stop and not pass down the family tree? Declan, maybe you'd like to kick off.
Yeah, it might be one for Joanne as well, actually. But if we take HCM, for instance, there's a 50% chance of inheriting that faulty gene. So you know, those are like the probabilities of passing on that faulty gene. So it is obviously possible that the family, you know, wouldn't inherit that cardiomyopathy gene, but different cardiomyopathies have different mechanisms of inheritance, and sometimes these genetic differences can arise without a family history as well.
Joanne?
Yeah, so I think in patterns of inheritance where there's a 50-50 chance of the gene passing on from the parent to the child, it's 50-50 for each child, male or female. All of the children could turn out to be gene negative. So in that branch of the family, it's obviously not going to pass on to the next generation. The condition doesn't skip a generation. So if in fact a parent doesn't inherit a faulty gene, then they cannot pass it on to their offspring. But in some situations, the parent has a mild form of the disease and the child has a more severe form of the disease. So it actually looks like the condition or the gene has skipped a generation, but it hasn't in fact. It's just that the parent has a more mild form of the condition. But to patients, sometimes it looks like it's skipped a generation, but it hasn't.
Okay. A wider question, should the whole population be screened for these conditions?
So I can start off with that one maybe. I think that's a super difficult thing to give a firm answer on. So I guess actually some of the research that I mentioned in our talk was essentially doing that. So Biobank is, you know, a sort of population of adults in the UK. We looked at their genes. We looked at those people who were carrying the genetic variants for HCM, for hypertrophic cardiomyopathy. That certainly carries an increased risk of events, of abnormal heart rhythms and of heart failure. But most people don't have any symptoms. So more than 80% lead normal lives. And also the other important thing to notice was that in the general population, if you carry that faulty gene, you seem to have a different pattern of disease than the disease that runs in families. So there's something else going on in families. And it's probably that within families, you inherit some other genes that affect that important genetic variant gene. So it's not a single gene defect. There are actually some more common genetic variants that would tend to go along with that rare genetic variant in the family, whereas that's not something you see in a general population. So actually, you know, that faulty gene can have very different effects on health depending on whether it's just in the population or whether it's actually in families. So people shouldn't necessarily expect to have the same sorts of outcomes and problems that we would see within familial disease. You know, I think it's super difficult, and I think it comes down to, you know, your personal viewpoint about whether you want to know about this sort of thing, about if there's anything that you can do about it, how it might affect your life, considering that most people lead healthy lives, even with these genetic variants. But I think increasingly it is going to be an issue because more people are having genetic screening for different reasons. And these genetic variants that cause cardiomyopathy will often be reported to patients. So I think then increasingly people who may have cancer or other diseases who have genetic testing, now have to face how they handle the news that they're potentially carrying this gene and could pass it down to their children as well. So I think it is a complex, difficult decision. But increasingly, I guess as well, direct-to-consumer genetic testing is going to become increasingly available, and people may decide to have these tests done on themselves or their families. But actually giving them really good advice about what the implications are for that, I think is, the data for that's only just kind of emerging really.
Yeah. By instance, John, of course, your service is more targeted, but any thoughts on the wider testing?
So I think I would concur with what Declan is saying, and I think it is quite a divisive topic, really, and I suppose there are different viewpoints depending on your situation and circumstances and where you're coming from. And I suppose if you come from a patient or a family where there has been a significant cardiac event or a sudden death within the family, they may feel more strongly about screening the wider population. I think from a medical perspective, in terms of clinical screening, so clinically assessing the heart, there's not just one, it's quite complex. There's not just one condition to screen for. There's not just one test that you do, and often within the clinical setting, patients require multiple tests, and some of the diagnoses are quite difficult to make. And also, there is an issue of whether the condition has manifested at the time of initial screening, where the initial investigations may look normal, but at a later stage, that individual may well manifest a condition that was underlying but wasn't evident at the time. So I suppose just there are lots of, other complexities really to be factored in, really.
Thanks, Joanna. One final question, big one, Declan. In the future, this comes from David, will inherited heart conditions be eradicated completely?
Well, that is the big question. Not in the near future, but there are some, as Nicola mentioned, there are obviously effective treatments, putting devices in. There are new drug therapies as well that are available. In terms of preventing them, that would involve essentially either changing the genetic, treating that genetic variant in the heart, or preventing the protein that the gene produces from causing a problem in the heart. Of course, often by the time people present with the disease, their heart has already changed in shape and may already have scarring within it, and so any treatment, if you like, needs to sort of reverse those changes that have already been accumulating over a period of years. I think there's some very interesting, promising therapies on the horizon for being able to treat these inherited diseases, and I think that's very much an intense focus of research over the next 5 to 10 years.
Thank you very much. Thank you, Declan, for sharing. Thank you, Joanne, too, for sharing, and Nicola for sharing your story. And to you, to the audience, thank you for joining us today. We hope you've enjoyed hearing from our brilliant speakers and how your support helps us to fund the most impactful science possible. Also, thank you to the Northern Ireland Science Festival for allowing this edition of Alive and Ticking to be part of the Science Festival. Remember, if you submitted a question that wasn't answered, or you'd like to know more about our genetic information service, then you can contact one of our clinical team by visiting BHF.org UK Information Support Heart Helpline. A reminder that this event was recorded and will be available on the Northern Ireland Science Festival YouTube for the remainder of the festival. It'll then be on the BHF website from the 20th of February. We hope you'll join us for our next Live and Ticking event. For more information and sign up, please visit the BHF website at www.bhf.org.uk/public events. Remember, the pandemic has hit us hard as a charity. So any donations to help fund our work and vital research, such as you've heard today, are very much appreciated. There's a link to donate should viewers wish to do so at the end of the event, which is bhf.org UK/I donate. Thank you all very much, and goodbye.